Well, good morning, everybody. My name is Larry Hoffheimer. I'm the chairman of the board of the Macular Degeneration Association. I'm pleased to have all of your patients and caregivers that happen to be joining today. As you can see, we are doing virtual programming for our patients that in lieu of the face-to-face seminars that we've been doing for the past 10 years. Unfortunately, until the virus has given us an opportunity to travel again, we're going to continue to do these virtual programs. And I suggest all of you, because they're all different, that you go to our website, macularhope, HOPE.org, and you'll find the list of future virtual programs. I also want to thank Regeneron Pharmaceutical and Novartis Pharmaceuticals for their support in these patient education undertakings. So I want to begin by welcoming our panel, or our educators, so to speak. I first want to introduce Dr. Jeremiah Brown. Dr. Brown is a distinguished member of the Macular Degeneration Association Medical Board, and he also has had more than 10 years of practice as an experienced retina surgeon. He founded the Brown Retina Institute in 2010 to establish a medical practice devoted to diagnosing and treating and research diseases of the retina. He is a clinical associate professor of ophthalmology at the University of Texas Health Center in San Antonio. The Brown Retina Institute has two locations in Texas. So it's now my pleasure to introduce Dr. Jeremiah Brown.
So good morning, everyone. It is my pleasure to be able to have this opportunity to talk with you about macular degeneration. Macular degeneration used to be something that people would dread with fear because most people would become legally blind from macular degeneration. Things have changed, and now most patients with macular degeneration do not become blind from their macular degeneration. So there's really been a revolution over the last 10 to 15 years. And what I want to do is walk you through where we were back then, where we are now. My patients come up with questions about, why can't we use laser? Or why can't we do surgery? Or why can't we, why does the injection have to be repeated? Why, or how long do we have to do this? And I want to give you a feel for the answers to all those questions. And we're going to start from the beginning. We're going to talk about the eye. We'll talk about the anatomy of the eye. And then we'll go into how did the treatment evolve from where we once used laser to what we're doing today. And then if we have time at the end, we'll talk a little bit about some new research studies that are going on right now that are going to further change our field. So when you hear about the word macular degeneration, what it's referring to is the part of the eye that's the macula. Here on this cutaway image, you can see the eyeball, and this area right here in the center is called the macula. This is the optic nerve over to the side and the normal blood vessels that all go through the eye. And this area is your central vision. That is termed the macula. So the macula is the part of the retina that does your central vision. So the macula is this area in the center that deals with your central vision, in the center of the retina. That's the macula. Now, if we dive into this a little bit more deeply, the retina is made up of several different layers. So you have the retina. So now we're taking that one section in the back of the eye, and we're looking at the different layers that make up the retina. So on the surface here, you have these cells, these kind of purplish rods and cones. These are the cells that actually capture the light. Underneath the retina, there's this layer of cells that take care of the retina. So think we're working from the inside of the retina, working further back to the back of the eye. So underneath the retina, there are these cells called the RPE cells. They're cells that take care of the seeing cells. They give them their nourishment. They recycle things. Then underneath that, there's this layer called Brooks membrane. Brooks membrane is a membrane that's supposed to be a barrier. It's a barrier between the retina and then what you see underneath it, which is this thick, rich layer of blood vessels. And that's called the choriocapillaris. So all these red blood vessels are blood vessels under here. These blood vessels are supposed to let oxygen get through into the retina, but not leak fluid and not cause, and these blood vessels should not grow into the retina. Now, to start our discussion about macular degeneration, it's important to know that there's two different types. There's the dry and the wet. You can start out with dry and it can change to wet. You can have dry in one eye and wet in the other. But you see on this slide here, it's saying people with dry is about 6 to 1, that most people have dry macular degeneration. If you have 7 people with macular degeneration, 6 of them will be dry and 1 of them will have the wet form. So let's talk about what do we mean when we say the dry form. So now we're looking at that picture of the retina one more time. Now we've got it situated up to down, so top to bottom. So these are the seeing cells sitting at the top. The light would come in like this, it hits here, and then you see it. These are those helper cells down here. And what you're seeing is this yellow protein deposit. Protein starts to build up in this layer of the helper cells over a person's lifetime. And if you have macular degeneration, you get more of this deposit, more and more of these deposits. And that affects how those helper cells work. Now, what happens when we look into your eye, this is how we can tell if someone has macular degeneration. Now we're looking into the eye and you can see all these little yellow deposits. Sometimes there's some pigmentation that makes them look with brown speckles and pigmentation within those deposits. This is what drusen look like. And these protein deposits are called drusen. So when you go to your eye doctor, they may be able to identify that you have these drusen even before you have any problems with your vision. So these come on slowly. It gradually accumulates through your lifetime. Usually we start seeing those maybe in someone who's turned 60 and older. Now, the drusen can cause problems in the long term because that material building up in those those helper cells causes those helper cells to start to thin out. And so what you're seeing here are these areas that look like a cookie cutter. Someone just took a cookie cutter punch out and you can see this pale area in the center. Those are areas where those helper cells have died off. So this is the degeneration. This is the slow deterioration that happens in the retina, and that's what happens in what's called the dry form. When we see these areas that look like cookie cutter cutouts, that's called geographic atrophy, or GA. So we go from the drusen to the thinning. And you can see this person still has some drusen out here, but they've got this thin area right in the center. In the area where the vision, your central vision, so we're looking at that right now, the macula, when you get thinning like this, you lose vision. This becomes a blind spot in your field of vision. So to summarize the dry type starts out with drusen. You may have some minor visual changes, maybe a little waviness, maybe a little distortion from these little deposits, but you're still seeing very well. As time goes on, when this atrophy or thinning develops, that can start out as a small little blind spot that can enlarge gradually over years to where you can have a large area of vision loss. So it can be a large blind spot right in the center of your vision. Now, at either stage, you could be at the stage where you just have drusen, or you could be at the stage where you're beginning to get that thinning or the atrophy. Both of those stages can lead to the wet form. So out of about 15 million people who have some form of macular degeneration, about 1.7 million of them have the advanced form, where they either have the wet or they have those large areas of gaps in their vision. Then we call it the advanced form. Now, so what is the wet form? The difference in the wet form, and the reason we call it wet, is because blood vessels start to grow into the retina. And these blood vessels can leak and bleed. So the key is that there's abnormal blood vessels growing in the retina. This is the leading cause of leading blindness in people who are over age 65. And about 200,000 people in our country every year get diagnosed with the wet form. So this is not a rare condition at all. So let's go back to our cartoon picture and talk about how this wet form develops. So here we see the retina sitting on top, and here's just an expanded view of that so we get a little more detail. Then we have these helper cells underneath the retina, these RPE cells, they're pigmented cells. Then we have that membrane, and then we have these blood vessels underneath it. Okay. So what happens with the wet form is you see this drusen. These are those protein deposits that we were seeing on that other picture. And you can see some of these blood vessels are trying to get into the retina. Why is that? The retina sitting on top of this deposit is not getting the oxygen that it used to. Remember, we talked about how the oxygen should come through here and get to the retina and help the retina with all of its functions that it needs to do. Well, if you get all this material building up, those drusen, then the oxygen can't get through as well. So your body makes a signal. That signal is a chemical signal that says, we need more oxygen up here. The problem is, the reaction to that is the blood vessels start to sprout and grow into the retina. And we don't want blood vessels in the retina because they can leak and bleed. So they start to spread. These blood vessels have broken through that barrier layer. Now they're starting to spread into the retina, and they just keep growing. This person might start noticing distortion. That's usually very often the first thing they notice, that things start looking wavy and curved, because now these blood vessels are leaking fluid, and you can see this curve of the retina over this little pocket of blue fluid. They just color it blue so you can see that it's fluid. It doesn't really look blue when we look in the eye. It's more like a clear fluid. But there's fluid there, and it's making this distortion, and that is why people will start to see things looking wavy or curved. Now, when we look into your eye, say you go to your eye doctor, you're noticing distortion. If there's a lot of bleeding, they might see something that looks like this, a pool of blood there in the center of the retina from these blood vessels that are growing into the retina. If that's not treated, it evolves into a scar like this. So that's a permanent scar that will take away the person's central vision. They probably won't be able to read nearly any letters on the chart. They have some peripheral vision, and they may have very good peripheral vision because the retina outside that scar tissue is all normal. But their central vision, the vision you use to recognize people's faces, to read details, their central vision will be missing if it's not treated. So to summarize that, we talked about the dry, where you have the drusen and then the atrophy or thinning. Then we talked about the wet, where you have abnormal blood vessels growing in that can leak and bleed. So now let's talk about what are we going to do about this and how does it impact people? We talked about how there's about 1.7 million with the wet form, but most people have the dry form. As we live longer, this is becoming more prevalent because these little deposits gradually increase through your lifetime. In the early stages, like we said, they might have mild visual disturbances, a little distortion, a few little blind spots. Even in the late stage, people rarely completely lose their vision. And that's an important thing. That's what I want everyone to take home from this, is that even in the worst case scenarios, most people, they lose their central vision, but they do have peripheral vision. So they can still see the doorway. They can see a chair. They can tell there's someone sitting in the chair. But in those far advanced stages, they're not going to be able to tell who that is sitting in the chair. They can't see the details. They can't see the facial features. So here's some examples. Here's some of the things that someone might see. So they're looking at words. The words are curving. There's little spots missing within the words. So this person could have dry or maybe early wet macular degeneration with some distortion, but they're starting to get little gaps in their vision. Here's an example of a bus where they can see that there's a bus there, but then when they try to look at the name of where that bus is going, there's a blind spot that's covering that. So they have peripheral vision, but their central vision is missing. Now, what are the risk factors for getting macular degeneration? Why doesn't everyone get this? So a large part of it is heredity. And we're going to talk a little bit about the genetics of this, but we know about 70% of your risk of whether or not you're going to get it is related to your family history. So not much that we can do about that. We talked about age. Not much we can do about that. Just as you get older, it's more common. In terms of race, it's more common in Caucasians, but it can affect all races. History of smoking. So we know that smoking makes this worse, and it increases your risk of the wet form also. If you don't have antioxidants in your bloodstream, antioxidants are chemicals that are naturally in our bloodstream that help take out toxins. You find antioxidants in things like green vegetables, fruits. So if you don't have a lot of that in your bloodstream, you're more at risk for developing macular degeneration. And people with high blood pressure are more at risk for developing macular degeneration. There have been some studies that say if you have a lot of sun exposure at a young age, you know, the sun causes UV light damage to the retina. That's a little bit controversial. It hasn't been for sure proven that more sun exposure, but we do know that in general, UV light is a negative for your retina. So we want to always encourage people to wear sunglasses with UV blocking filters on them. And then if you have cardiovascular disease, you might be at slightly more risk, or it may be just that the risk of that is similar to the risk for macular degeneration. So it's not that the heart disease is causing the eye condition. It might be that they both are related to having more protein deposits, plaque building up in the arteries, and we've got protein deposit building up in the eye. It may be related to the same underlying things, which are low antioxidants, having a high fat diet. Those kinds of things might give you risk for both things. So the genetics, we talked about that, just touched on it. We now know the major genes that cause macular degeneration. And so they've done many, many, many family studies proving that if you have a family member with macular degeneration, you are more likely to have it. And they've been able to find what are the genes that are being carried down through the generations that give that risk. Some of them give a lot of risk, some of them give a small amount of risk. And they can actually calculate what your risk of progressing to that late stage is by doing a cheek swab and sending it off to a laboratory. So that's a test that's available right now if someone wants to know what their risk is. And you can see in this particular person, based on their profile, these are the genes they have listed down here, but they could plot out that over this next 10 years, their risk may go from 10% all the way up to 65% that they're going to go on to that advanced stage. So this is someone who has a high risk for their macular degeneration progressing. So this is a person who's really going to need to take care to do the things that will help reduce that risk, and we're going to talk about that. So how do we, when the person comes in, what are some of the tests that you might undergo? One of them is the Amsler grid, and we like people to have this at home. It's just a piece of graph paper that has squares, and you look at it one eye at a time. You cover one eye and look at it, and these lines should all be nice and straight. You try to keep your focus on the dot in the center, and then try to see the other lines with your peripheral vision, and those lines should be nice and straight. As time goes on, a person might start to see this waviness, like you're seeing in this center box. That waviness is from those little deposits, and it might be actually from blood vessels growing into the retina. So if you start to see waviness on your grid that you didn't have before, definitely should call your doctor, come in, have us take a look so we can see if there's the wet form beginning. You might have a spot, like just a total spot, that's called a scotoma. A central scotoma is what it's called when you have a blind spot. So if you see a blind spot on your grid, another reason to call and come in for an exam. One of the tests you might have is called a fluorescein angiogram. This is a dye test. It helps us see the circulation in the eye. So you'll be sitting at a camera, the technician will inject a dye in a vein in the hand, and then we can see that dye as it enters the eye. So here on this picture on the bottom left, you can see the blood vessels are looking white. That's the dye in the eye. You can see all these little drusen, those little yellow deposits, they're lighting up. Now, they'll take pictures over several minutes. And what happens in this person is after a period of time, you can see this one area lights up real bright. The dye is fading out from all the other areas, but it's lighting up here because it's leaking. So the dye is leaking into the retina. That's the gold standard to say there's abnormal blood vessels there in that person's retina. This is what it might look like on another person. It's a little more crisp and clear, where you can see this little network. It almost looks like a little piece of broccoli growing up out of the retina. It's growing from underneath the retina into the retina. That's another way you might see it looking like that. And then in this case, this is that person that had the hemorrhage. So the hemorrhage is out here. It's causing a shadow on this picture because the dye, you're not seeing it as well because there's blood blocking it. And you can see this thing lighting up in the center, which is this area. There's a growth of blood vessels in the center that are causing this bleeding. And then that's the end stage scar that develops if it's not treated. Now, another test you might have is called an OCT scan. This is giving an image of the cross section. Now we're looking at a cross section like we were looking at on those cartoon images. So this part here is the retina. There should be a nice gentle slope down to the central vision. Then it comes back up on the other side. That's a normal retina. And these are all the layers of the retina. This bright red line, that's that barrier layer that blocks the retina from these little blood vessels that are underneath here. So this is a normal OCT scan. That's the way the retina should look. What's wrong on this picture? You can see it's not smooth. This orange layer has a little bump in it. There's fluid here. You can see this dark space underneath the retina. This retina should be flat against the wall of the eye, but it's lifting up because there's fluid leaking in. Here's another example. You can see this dome-shaped curvature because there's blood vessels growing in from underneath, and then they're leaking into the retina. This retina looks swollen. It's thicker than it should be. And that's another sign of wet macular degeneration. So that's when it's converted from dry to wet. So what are the treatments that we have? First of all, everyone with macular degeneration, in fact, everyone in general, should be having green leafy vegetables in their diet. It's been proven. They've looked at genetic studies in people who are at risk for getting macular degeneration. The people who had more green leafy vegetables, spinach, kale, collard greens, turnip greens, the leafy greens, had a lower risk of progression, even though they had the genetic risk for it. The rate that they got the macular degeneration was less if they had more green leafy vegetables in their diet. Having fish once or twice a week, that's all it takes. A couple times a week lowers your risk. So you want to go with the fish that are the oily fish like salmon, sardines, mackerel, but basically all fish is better than not having it, but especially salmon tends to be very good. We talked about UV light protection. So when you buy sunglasses, make sure it says that they block UV light. Now, once you get to the intermediate severity, that means you have many of these drusen, and your doctor will tell you this. You have more of these drusen, or you have the beginning of this thinning, or if you have the wet form, as you can see down here, we've written down, or you have the wet form. If you're in this stage, now is when we consider the vitamins. So the vitamins were studied in a large study called the AREDS trial. And when you look in the store and you're looking for the vitamins, you want to make sure it says AREDS on the bottle. It just stands for the Age-Related Eye Disease Study. They studied over 4,000 patients and followed them for 10 years. So this is a huge study. It's very hard to do a study like this with that many people. They were looking to see, did it affect their vision, how the disease progressed, did it affect their risk for cataracts and macular degeneration? Well, they were looking at seeing how many people progressed to that advanced form or how many people lost vision, like 15 letters on the vision chart. So the AREDS vitamins, the original formula had vitamin C and vitamin E and beta carotene, which is a form of vitamin A, and zinc. And because when you have extra zinc, your body tends to lose copper. Copper is added to it also. So that's what the label will say if it's an AREDS formula. Now, what they found is it reduced the rate of progression by 25% just by taking this vitamin. One tablet twice a day reduces your rate of progression. So that's tremendous. That was great news. Now, that vitamin, like we said, had beta carotene, which is a form of vitamin A. People who have a smoking history or a history of lung cancer, they actually should not take vitamin A, can increase their risk for lung cancer. So as a safer option, they did another study, AREDS 2. They took out the vitamin A and they put lutein in. Lutein is a natural protein. It filters out blue light. It acts as an antioxidant. Remember we were talking about those, how they detoxify things in the system. So they took out the vitamin A and they redid the study with lutein to see if that would give just as good effect. And thank goodness, the amazing thing is with this formula of vitamin C, vitamin E, then they added the zinc just like before, and then they added lutein and zeaxanthin, which is another yellow pigment that's in the retina. Lutein is also in your retina, so it's one of those antioxidants that actually lives in the retina naturally. We're adding it extra of that in this vitamin, and they found that it did reduce that risk in the same way. As a part of that second study, the AREDS-2 study, they had an arm looking at omega-3, so the fatty acids that are in fish. You hear a lot about omega-3. It's in things like the fish oil tablets or flaxseed oil. Well, the omega-3 addition didn't reduce the risk. So it's very interesting. So it sounds like there's something about natural fish that's better than taking it as a fish oil tablet. So just have your fish twice a week. Who knows? Maybe it's just that when you have fish, you have fewer hamburgers. And so that way you don't have as much of the negative fats and lipids that get deposited in the retina. But whatever the cause is, having actual fish in your diet is better than just taking a fish oil tablet as far as macular degeneration. Fish oil tablets do help with lowering your cholesterol, though. I mean, that is proven. We know that. But in terms of macular degeneration, real fish is better than having the omega-3s. And that's basically what this slide says. So the AREDS-2 formula with lutein also decreased the risk of progression by up to 25%. Now, let's get a little bit deeper into this. And if you just remember what I just said, that's the bottom line. But let's go one step deeper and look at, we talked about the genetics and the genes that you inherit. Everybody inherits a slightly different profile. Remember, we said there's multiple genes that give you that risk. Some people might inherit 2 or 3 of those genes. Some people might inherit 5 or 6. Some people might have 2 or 3, but it's a different 2 or 3 than their neighbor who has macular degeneration. So everybody's macular degeneration is a little bit different. They went back and looked at the AREDS study, and they looked at all these different genetic profiles and tried to understand, do the vitamins work equally for everybody? And it's interesting that it's not equally from everybody. For some people, it works a huge amount. For the average person, it is definitely beneficial. So the average person, it definitely helps. There's a small group, maybe 10% to 12%, where actually the zinc that's in the vitamins didn't help them and may actually have a negative effect on their macular degeneration. That's maybe 1 in 10 people where there might be a risk of having that extra zinc. So you remember we talked about that you can actually do a genetic profile. So that test that we were talking about before, that is a test that can be ordered, and you can find out whether you're one of that small group where the extra zinc in the vitamin may not be beneficial. For people who are in that group, they take the other vitamins, so you can now buy it without zinc, and they still get the benefit of the other vitamins that are in it and the lutein. They just don't get the zinc. But the vast majority of people, more than 85%, taking the vitamin is overall the right thing to do. It's going to help slow the progression of your macular degeneration. Now, let's talk about wet AMD. Wet AMD, because it's the one that causes the most vision loss, is the one that a lot of research has been done on. We talked about how these blood vessels grow up into the retina and then they leak fluid into the retina. So the first idea was, well, why don't we use laser? Could we use laser to seal these blood vessels? And that was the first treatment that started back in the 1980s. Laser was done. You'd see this laser beam coming in, and it would kill the blood vessels. It would halt their progress. The problem is, as you can see, it passes right through the retina. So it also kills the healthy retina. So it created a blind spot in people's vision. So even though they didn't get better vision, it stopped it from getting worse, but it created a permanent blind spot. And in fact, the blind spot might have been darker than what the original vision was like from the macular degeneration. So then the next step, let's go to the next way of treating it, is with using a cool laser. So basically by cool, I mean it doesn't heat up the tissue as much. And the difference is that a dye is injected, kind of like when you're doing the pictures, a different dye is injected, and that dye goes into the retina, and that dye gets concentrated in the abnormal blood vessels. Then the laser activates the dye. So here this dye is called verteporfin, and it's given as an injection. And then after a number of minutes, a laser is done, but not as intense as that previous laser. But here you see the laser beam going into the eye, and it kills the blood vessels that have the dye in it. So it definitely was a step forward. Here's that example. Now we're using a laser that mostly gets absorbed by the blood vessels. But unfortunately, it does do some damage to the tissue around it. So it wasn't a perfect selective killing of the bad blood vessels. It did affect some of the healthy blood vessels and the healthy tissue around it. It wasn't as bad as regular laser. It was a step forward, but unfortunately, people still lost vision. So here's an example of how that blood vessel shrinks away. Here's an example of showing someone where on their angiogram in the beginning, you can see this little growth of blood vessels right at their central vision. And then after that dye and the laser, you can see that that blood vessel is no longer there. You can also see some of the healthy tissue around it is not circulating as well either. So it was a step forward. It didn't cause as much damage, but it still caused damage. So that's the reason. And this is just a graph of how people's vision did. So across this axis is time, months going by over 2 years. And this one is how many letters did they see on the chart. And you can see everything's going downward. The people with no treatment, they lost the most vision. The people who had the dye with the laser, they lost less vision, but they still lost vision. So that was where we were around the 2000s, 2001, 2004, 2005. That was the best thing we had. They did a study looking at surgery. Some of my patients asked, why can't we just do a surgery, go in and pull these blood vessels out? Well, actually, you can do that. You can go in and grab onto the blood vessels and pull them out. The problem is, remember how those blood vessels grow up through that layer? That's the nurturing cell layer. Well, the problem is when you pull the blood vessels out, those helper cells also get pulled out. So it just creates a permanent blind spot. So yes, you can stop the bleeding, but the person still has a permanent blind spot that's very large. And so their vision did not improve. So that was abandoned. So now we no longer do surgery for this disease. So what happened? All of these medicines that you see on the screen here came along, which stopped the chemical that's telling those blood vessels to grow. You remember how we talked about how the retina is feeling like it's not getting enough oxygen. So it sends out this signal telling blood vessels to grow in, but we don't want blood vessels to grow in when it's the retina. It's okay, let's say it's another part of the body. Let's say you've broken your leg or you have a heart attack and there's a damaged, injured part of the body. The same chemical is used, and it's amazing. It's amazing. The same chemical is released by the tissue to heal your heart muscle, and it's telling it, grow more blood vessels. We're not getting enough oxygen in this area. That same chemical is being released by the body to help heal in any injury like that. But in the eye, when these blood vessels grow in, they're causing damage. So we want to block that chemical. And so this is why it's given directly to the eye, because we only want to block it in the eye. And the second thing is, we don't want the abnormal blood vessels there because they're going to affect the person's vision. So let's talk about these medicines a little bit. So the gold standard now is to use an injection. It gives better vision. You don't get the scarring that you get with laser, and you're more likely to improve your vision, actually, if you have an injection versus having laser. We numb the person's eye with drops and gel. Some people who are very sensitive will actually inject a little anesthetic on their eye so that that area is numb. We then clean the eye with betadine. It's like an iodine solution that prevents infection. We do the injection at this area. There's a point on the eye where you can inject a very small needle, very small. It can go in an area where it doesn't affect the retina and it doesn't hit the eye's natural lens. And that medicine goes in and it will dissolve down to the retina and block that chemical. So now there's no longer that signal being sent to make blood vessels grow in. After we do that injection, we rinse the eye. Most people will use tears on the day after their injection. Some people will use a NSAID or just a non-steroid anti-inflammatory, kind of like an ibuprofen, but in a drop form. a drop form of ibuprofen to help relieve any inflammation or irritation they might have for that day or the next day after their injection. Most people just use artificial tears and they do just fine. So this chemical we talked about is called VEGF, or vascular endothelial growth factor. So it's a growth factor. It's a growth factor that makes blood vessels or vascular endothelium grow. And that's what causes the wet macular degeneration. The first drug that was found is called Macugen. That one didn't work that well. You can see on this picture, once again, everybody's vision is going downwards, a downward slope. It's just the people who got the Macugen didn't go down as much. So that drug was a help, but it wasn't really that effective. Then came along Avastin. Avastin helps block blood vessels in the same way. It was actually first designed to treat cancer. So the first patient where they studied this and was actually someone who had cancer. They were getting Avastin injections for their cancer, and lo and behold, their macular degeneration got better. And that was something that was never seen before, seeing someone's macular degeneration get better. So from that idea, from that one patient, it led to the idea of injecting Avastin into the eye. It really wasn't designed for the eye to begin with. It was designed to treat cancer patients, but they found when they injected it into the eye, it actually worked. And let me show you an example. Here's one of those very first patients where you can see their OCT scan shows this lumpy, bumpy, disorganized retina from fluid growing into it. They got their injection and the retina started to smooth out, smooth out. They got another injection, it smoothed out more, another. When they stopped, you could see it starting to come back again. And then they got the next injection, it smoothed out again. So they could show that, in fact, the Avastin was helping stop the leaking blood vessels. Next came Lucentis. Lucentis was one that was designed for the eye. And it's basically a modification of Avastin. It's just a smaller part of the Avastin molecule. So this is just a cartoon showing this whole molecule, which is an antibody. And they took a fragment of it, just the part that binds the abnormal chemical or the chemical that's in the eye, that growth factor, and they developed that into being a medication. Whereas the Avastin molecule is a larger molecule that binds it. Part of the reason they wanted to make it smaller is they wanted the body to be able to dissolve it quickly so that it's in the eye, gets dissolved in the eye, and not as much affects the rest of the body. So this is the study for Lucentis, and Lucentis came out. You can see the average person who didn't get it, their vision's going down. This is this bright green. Their vision's going down on that graph. The people who received Lucentis, their vision's going upward. And you can see gaining 5 letters, 10 letters on the chart over a 2-year period, and they maintained it by getting injections. And there were 2 studies, there's just another study that showed the same thing. Next came Eylea. Eylea came out in about 2011. Lucentis was in 2006. Eylea was designed to bind that chemical. Again, you can see this molecule here binding this orange chemical, but it binds a little bit stronger than Lucentis does. So the goal was to see if it could last longer. They did a study to show that they could give Eylea every 8 weeks and get as good results as Lucentis every 4 weeks. But I will tell you, this is not something that's for everyone. Like, doesn't work. It's not a situation where you can just say, well, if I'm on Eylea, I only need injection every 8 weeks. There are people on Eylea who still need it every 4 weeks, because if we do it less often, the blood vessels start to come back. So it definitely was another advancement, and it helps for many patients, but the vision, in order to maintain it, some people still do need the Eylea more often than every 8 weeks. This is just a group of pictures from the original study showing that in everybody, the Lucentis group, the Eylea group, the Eylea every 4 weeks, the Eylea every 8 weeks, everybody's gaining vision. Everybody gains about the same amount of vision, whichever medicine you use. It's just a question of, will one medicine last longer for you in your eye than the other medicine will? But the amount of vision gained is the same, whichever medicine is used. Okay, so that brings to the issue this challenge of, how do we deal with this in our patients, these monthly injections? Some offices will treat continuously, where they just get injections every month, because that's how the studies were done, every month. We know that if we treat you every month, we're going to stop these blood vessels and keep them under control. The issue is, though, not everybody needs an injection every month. So some doctors will treat as needed. They'll get it to where it's stopped leaking, and then they'll stop and watch. And then at some point it's going to start leaking again, then they'll start the injections up again. That is a legitimate strategy. The issue is, though, you have to go in pretty much every month to get it checked to see if it's starting to leak, because we don't want to let it leak to the point where you're starting to lose vision and then have you come in. We want to get it before you lose vision, because sometimes if it starts leaking or bleeding, you might lose vision that you can't get back. So we try, rather, another strategy is called treat and extend, where we'll treat every time when the person comes in, but we're going to extend their time longer. So we're not going to ever just totally stop, because we don't want it to come back. But we're also mindful that it's hard to come every 4 weeks. So we're going to try to extend you. We'll go to 2 months. If it shows that you can go 2 months and it doesn't leak, we'll go to 2 months. Then we'll try to extend it out to 2.5 to 3 months. If you can go that long and it doesn't leak or bleed, we'll treat you on that schedule. So it reduces your visits. You're not having to come every month to see if it's leaking or not. And we can maintain good vision with that strategy. So those are some of the strategies for dealing with that issue. One of the problems that happens is, even with this, people still do lose vision over time. It may be stable for 2 years, 3 years, 4 years, but there may be some slow loss of vision. And some people, their blood vessels are just more difficult to control. So know that there are resources out there, and the people from the Low Vision Clinic are going to talk with you about this, but this is a very, very important issue. People become depressed when they're losing their vision. Talk to your doctor about it. Using antidepressive medicines, or maybe counseling, or maybe group therapy. We have groups that get together where people talk about their macular degeneration and the issues they're dealing with. Just being able to talk with other people really can help. And then there's the issue of registering for disability. There are programs out there that can get you the devices. If you're registered as disabled, they can get you these devices at a minimal or no cost even. So the take-home points of all of this is knowing what's wet versus dry. In everyone, we want you to monitor the grid so that if you do turn to the wet form, we catch it early. There are multiple different genes, as well as how you perform in terms of what's your diet like. Are you protecting your eyes? Are you a smoker? All of these things contribute to your risk for this macular degeneration. So take control of the things that you can control. Eat well, don't smoke. Remember that everyone's macular degeneration is not the same. Your neighbor might be going in once every 4 months and they're seeing great. They're doing great. You might need an injection every month, but you're also doing great, but you just can't go every 4 months because yours starts leaking again. That's okay. If we can control it, we do what we need to do to control it. Take the vitamins. If you're in that intermediate stage, and your doctor will tell you that, if you have enough of those drusen where we know your risk for having the more severe form is going to go up, take the vitamins, because it definitely reduces your risk. And then the last thing is knowing about this chemical, this growth factor. That is how we treat macular degeneration now, is by stopping that growth factor. And all the medicines that you heard about do block that. The future of this is now medicines are being developed that last longer in the eye. There's also ways, even a little port that's being sewn onto the eye, that will allow that port to be filled with medicine maybe once a year, once every 8 months. And so the person is not needing injections every month. That port would slowly release the medicine over, as long as there's medicine in it. So maybe it needs to be refilled once every 8 months or once a year. These are things that are being worked on right now. So you're going to be hearing about new medications coming out in the next year or two. They're not that far away. You're going to be hearing about this port that's being developed. It's in its final studies. So hopefully that will turn out to be effective and safe. So we'll be hearing about that to come out. So I want you to know that the future is bright. Macular degeneration has gone from something where most people used to go blind from it. Now most people are keeping their vision. So remain encouraged, follow up with your doctor, get your exams, go in if you do have any changes. And that's my summary. So it's a pleasure talking with you about this. Is a topic very important to me and near to my heart. So thank you very much.
Dr. Brown,
Yes.
how come you didn't mention Bayview?
Okay. So I was worried I was going to run over time. So Bayview is, I have a kind of a little extra addition to that talk, but Bayview is one of the newer medications that was one of those where the goal was to make it last longer. What we found was about 50 to 60% of patients could get one injection every 3 months and do just as well as someone getting, say, Eylea every other month. Now, the interesting thing was, in all the studies, it did very well, and the medicine was approved. Once the medicine was released for use, we started seeing some cases of inflammation. Inflammation can cause vision loss. So you can have mild inflammation where you might just have a little bit of floaters in the eye and use some eye drops and the vision comes back to normal. But some of those people actually had severe inflammation where they would even lose vision from the inflammation. So Beovu definitely is an advancement. It's a medicine that lasts longer and gives the same vision improvement with fewer injections in most people. But doctors have been a little bit cautious in using it because we don't know who that person is that's going to get that inflammation. So most cases now, we're leaving that as a medicine that we use in the people where we just can't get it to stop leaking. We've used Lucentis, we use Eylea, they're still getting leakage. We'll go on to Beovu. But with the knowledge that the person is taking a little bit of a risk that it could cause some leakage, or inflammation rather, it could cause some inflammation, which on a very rare person could be inflammation that might actually damage their vision. But in many people, it works very well. So I have patients in my practice where we use Beovu. Fortunately, we haven't had any bad reactions, but it is a risk with that medicine. But it has extended the time between injections for some people where we could never go longer in the past. So Beovu is one of those advances. I have a lot of questions about genetics and a lot of questions about future. So I think in our next talk, so watch the Macular Hope website. The next time I'm speaking, I'm going to direct more toward what's the future, what are the studies that are going on right now,
Good.
and we're going to touch on these because I see some questions that I can answer right now. But we'll do an expanded. I have a whole presentation just on research and where we're going and what's the next thing. So look out for that on the Macular Hope website. But one person asked, so someone who's already lost most of the vision, are the shots helpful? The key is, if you still have leakage in your retina, and that's what you ask your doctor, is the angiogram or the OCT scan, is it showing that there still is some leakage? If there is, then yes, it might be helpful because the fluid in the retina damages the vision, even if your vision is only where you can see fingers in front of you. I've had patients where they could only see fingers in front of them. Once they got treated, the fluid absorbed, and now they're seeing like the big letters on the chart. So yes, the vision can still be helpful even if you lost nearly all your central vision. It still can be helpful if there still is leakage in your retina. So next question is about the 4C home device. This is also in that new products presentation. So this is a little device that you can use at home to monitor your vision. It's very effective. Some people like it better than using the Amsler grid because it's more like a video game. You know, you're looking at a screen and you touch where you see the little images pop up for a second. And that device can help identify people who are losing vision, maybe sooner than waiting for your next appointment. And so it's a very helpful device for people who are interested in it. It's covered by Medicare. So ask your doctor about the 4C home device, and we can get you signed up for that program. You get the device at home. And when you start making more errors on your testing, we at the office get an alert. We get an alert saying, you know, Mrs. Jones is making more errors. She should come in for an exam. So we have her come in, maybe it's a month before she would have come in, and we're finding we're catching the macular degeneration earlier when it's changing to the wet form. Another question is saying, how about restoring vision loss once it's there? So there is research going on with stem cells. So stem cells can be used in many different ways. You could have stem cells whose job it is, like these are cells that we're putting in the eye, whose job it is, all they do is they're producing a chemical. So they could be producing what avastin is. And they could have those cells in the eye slowly making avastin so that maybe you get an injection of those cells once a year or once every 2 years, and they make the avastin. That's one way stem cells could be used. That's being looked at. Another way is injecting the cells under the retina to try to regrow tissue that's been lost. That's another thing that's being looked at. Nobody really knows what the best strategy is. There are studies being where the cells are just injected under the retina. Some of the studies where they're injecting a sheet of those cells on a little, almost kind of like a plastic sheet, and that goes underneath the retina, and it has a layer of all those helper cells to help the retina on top. All of these things are being looked at right now. Right now, there's no clear, definitive answer on whether it's going to help people see better. That's being worked on, but definitely know that that is in the works. One person asks, we hear about all these different medicines, what's considered the best one? Really, the best one is whatever works for you. If you're getting avastin and it's working, there's no leakage on your pictures, you're able to go a reasonable period of time, maybe you go a few months and you're not leaking, that's good, that works for you. But if that's not working, then usually they'll switch you from avastin to Lucentis or Eylea. And if those are not able to control it, then maybe Beovu, just because they last longer. And so that's kind of the strategy that we use. If something's working, we'll stick with it. If it stops working, then we may shift to another medicine. Then one person asked about, is it possible to have wet AMD as a young age? And then the question was in a 20-year-old. So in a 20-year-old, then this is not typical macular degeneration, because macular degeneration is really age-related. There are other types of macular diseases or macular dystrophies or macular scars that can cause blood vessels to grow in the retina. So anytime you have a defect in your macula, you might get blood vessels growing in, and all of these medicines will work because they stop the abnormal blood vessels. But when you're only, say, 20 years old, it's probably not typical macular degeneration. There are some families where they have a very strong form of macular degeneration. Maybe it might come on, say, in their 40s, but I would say that's very rare and it's not typical. But when you're talking about someone in their 20s, then it's probably not macular degeneration. And then kind of the same question, this is just a variant of the other one, is should I switch from avastin to Lucentis? I would say if it's working for you and your vision is stable, you don't need to switch. That's my answer to that one. Are there any consequences to taking AREDS vitamins if you're not sure if you have macular degeneration? So here's the deal. I'm so glad someone asked that question. You should only take these vitamins if you've already been told you have macular degeneration and it's more than just a few little drusen. It's more like that intermediate stage. That's where the studies have proven it. So someone who just has, say, a family history, but they themselves don't have macular degeneration, they really shouldn't take these vitamins. Eat well, eat the greens, have the fish, even if you have it in your family, just make sure you're getting your eye exams every year. If they say, okay, now I see you're developing macular degeneration, that's where we know it's proven to help. These vitamins, it is a high dose of zinc. There's a high dose of vitamin E. And if you're taking other vitamins on top of it and you're taking it for a lifetime, you just never know. You don't want to take something that might be a risk to you if you don't even have the condition. So I would say don't take it if you don't have a diagnosis of that condition. So that last question, there's another question about the zinc issue. So the zinc issue, I would discuss that with your primary doctor. It's not something that you will get an answer for from taking the 23andMe test or one of those home genetic tests. Those basically are telling you, do you have any copies of the gene that can cause macular degeneration that gives you that risk? So it's telling you about the risk, but it's not telling you what vitamin supplement is the best for you. So I know we've kind of hit our ending point, and I want to be respectful to people's time. There still are some more questions here. But I would definitely have you look out for our next webinar, and we'll go into more about, the future for macular degeneration.
Next speaker, I think you're gonna find very interesting. Her name is Shirley Crandall. She's an independent living skills trainer at the San Antonio Lighthouse for the Blind and Visually Impaired. She began this field in psychology and was intrigued by her working with children with various learning disabilities. It led me into the field of applied behavior modification, where she honed those skills over the next 20 years. This laid the foundation for the training skills needed to teach individuals with visual limitations new ways to accomplish activities in daily living. Her position with the San Antonio Lighthouse has helped her discover a new passion advocating for caregivers as well as the patients. Part of her position with the Lighthouse is a facilitator of low vision clubs, where she is interacting with family members and individuals with low vision. So it's now my privilege to present Shirley Crandall. Shirley, take it away.
Thank you so much for having me here today. It's a pleasure. Very interesting to hear Dr. Brown's presentation. So I'm going to start sharing my screen with you, and we will get started on what we can offer to individuals that are having issues with their vision. So as Larry said, I'm with San Antonio Lighthouse for the Blind and Visually Impaired. I am with the Adults and Seniors program, and I'm an independent living skills trainer. And what we do is assist individuals with low vision in learning different ways to complete their daily activities independently. So our mission is providing adults and seniors the skills, tools, and resources needed to maintain independence in their home and in the community. The picture is of one of our orientation and mobility trainers working with one of our consumers using a long white cane. It's very important to maintain that confidence in your mobility so that you are able to go out and be independent and do all the things that you enjoy doing. And we'll get more into that. But first, I just want to go over some of our top 5 tips to help if someone is experiencing visual impairment. The use of talking items, and I have some devices here. We have a talking keychain, and it's a very small device with a raised rubbery oval button. You don't need any remaining vision to locate that button tactily, and you can press it for the time. It is 8:25 p.m. So the time will be spoken aloud to you. There are obviously other options for that, Siri and things of that nature, but not everyone has access to that technology. So we are a nonprofit. We are able to provide these items free of charge. And so that is one of our most popular items. People tell us that they really have difficulty telling the time sometimes, and that way they can hear it audibly. Our next cue for people is a tactile item. And so we have a large print pillbox with Braille in the corners. So if somebody knows Braille, then they would be able to still know the letters of the week on their large print pillbox. This item is also demonstrating not only large print, but good contrast as well. It's got bright blue on a clear background, so it makes it easy for those letters to pop out. And then also the last of our top 5 is lighting. So having good lighting is very crucial. It's creating a little bit of a glare on this video, but I'm hopeful that you get the idea that just adding some light is going to be able to help you in seeing what you're wanting to see. Keep in mind with task lighting, you want it right at or below your eye level. You don't want that bright light from coming above you. And most people do well with a good crisp daylight type bulb. That's a good kind of white to blue type light. Those with glare issues are going to want to choose something with a more yellow tone. So those are our big top 5 tips for individuals that are experiencing low vision. What we do here at the Adults and Seniors program is provide the independent living skills training, which in the time of this pandemic is looking a little bit different than usual. Typically, we would go to consumers' homes to provide in-person training on devices. And what we have adapted to do now is to mail out those devices after we have done a phone assessment to determine what would be most appropriate for them. And then once the consumer has received the items in their home, we will do either a Zoom training or a training over the phone. We also offer orientation and mobility training. I showed you the picture before of one of our certified orientation and mobility specialists providing that training with the long white cane. Having confidence in your ability to move around independently and safely is very, very important. It goes a long way to your overall self-confidence and independence, and that contributes to your quality of life. Like Dr. Brown mentioned earlier, sometimes people experience depression along with that vision loss. So we want to try to combat that in a few ways. He mentioned low vision clubs, and we'll speak about that in a moment. But increasing that self-reliance and self-efficacy with tools like orientation and mobility training, as well as our next service, which is our counseling service. We do partner with licensed professional counselors to provide between 3 to 5 separate 1-hour sessions. So they're going to follow you over the course of a few weeks. And their service is twofold. First of all, they're going to provide that impartial listening ear, because we all know that we have not shared everything with our family members because we don't want them to be concerned. We don't want them to burden them with our concerns. So we hold that in, and that's not being a great friend to ourselves. So our counselors can be that impartial ear where we can just share all those concerns with the counselor. But most importantly, the counselor is there to provide coping skills and strategies to help that person move forward in a positive manner. They're going to help to accept the changes that come along with the vision loss. And one thing that really kind of hit home for me early on in my training was I didn't really realize that, or it didn't put 2 and 2 together, that it's grieving the loss of something. Just as in we typically think of grief dealing with the death of an individual, in this case, we're dealing with the death of one of our senses. And so it's a very similar grieving and coping process that people need to go through. And a lot of people just don't really think of it that way. And so I think that contributes to the difficulty. So our counselors can definitely help provide that professional service. We also can provide referrals to our low vision clinic. Our low vision specialists do very detailed eye exams. They generally take around 2 hours. Now, they are very different than your regular ophthalmologist. The low vision specialist wants you to still be followed by your regular eye doctor routinely, because your ophthalmologist is going to be doing the things such as Dr. Brown was talking about, the surgeries, the injection procedures, things of that nature, while the low vision specialist is solely concerned with maximizing remaining vision. So they are going to be able to provide different things like lighted electronic magnifiers or solar shields and things of that nature to be able to assist in maximizing that vision that you do have left. And looking on the bright side, just like Dr. Brown said, macular degeneration is no longer usually a cause of complete vision loss. And there have been improvements in the amount of vision that is lost. So always got to look on that bright side. And our last service is our diabetes self-management education. Individuals with diabetes do have a higher incidence of different types of eye diseases. And so we want to teach them how to best manage their diabetes. They go through 7 topics that are curriculum put forth by the ADCES, the American Diabetes Care and Education Specialists. I am also an ADCES licensed lifestyle counselor for diabetes prevention. So basically it's overall wellness, doing those things to help keep you healthy, minding your nutrition, keeping active. All of those things are going to help either prevent if you are prone to diabetes or pre-diabetic. It's going to help prevent that disease from actually progressing. Or if you are diabetic, it is going to help you to hopefully mitigate some of those complications, or hopefully not experience those complications at all. So we are a nonprofit. We are able to provide these services free of charge. We are also grant funded. So we do have an income parameter with regard to the low vision clinic. If someone has a monthly individual income above $1,300, we are going to ask that they run that visit through their insurance or speak to this clinic about a sliding scale payment. We will certainly still provide the referral. And then they would also be responsible for the cost either through their insurance or the sliding scale for any devices that were prescribed. If someone is below the individual monthly income of $1,300, we will cover the cost of that low vision specialist exam, as well as up to $500 worth of devices that may be prescribed. A device is not inclusive of eyeglasses, but it does include those lighted electronic magnifiers, telescopes, different things of that nature. Again, we offer low vision clubs. We offer them in San Antonio and all of the surrounding areas. We have moved to virtual at this time, with the exception of Fredericksburg. We are meeting monthly. We just started our first in-person meeting last month again in Fredericksburg. And so hopefully sooner than later, we'll be able to start moving toward keeping those good socially distant, masked, yet in-person meetings starting up, because we do love to see all of our members. And the picture that I have here is of our Kerrville Club. And so what we do is not only do we provide that time to share experiences and share best practices and things that we've learned or frustrations, but we also have a speaker on a different related topic. And this particular meeting, we had a speaker from Wild Birds Unlimited, and she did a program called Birding by Sound, so that you would be able to recognize the different calls of the more native birds to our area just by their sound. And really, if you think about it, for all of us, sighted or not, it's often very hard to see exactly where that little bird is to know which bird is making that sound. So it was a very fascinating presentation, and our consumers really enjoyed it. So we do try to have a good mix of things like our orientation and mobility specialists or doctors, as well as some fun recreational type content for our meetings as well. So if you would like to join us virtually, please reach out to us. Our phone number is 210-531-1547. If you feel you would benefit from our services, you can go to our website, salighthouse.org. Right at the top left, you'll see a button that says Refer for Services. Click on that button and just fill out a quick form, and we will be in contact with you to get those services started. So if anybody has any questions, you can go ahead and start typing those into the chat box while I quickly go over all of the virtual ways that you can connect with us. Now that we have been making some changes because of the pandemic, we haven't been able to do outreach in our normal manner. We have a YouTube channel, San Antonio Lighthouse for the Blind, and there you can access lots of videos on the different types of adaptive aids we have. We have videos from our diabetic educators, our orientation and mobility specialists, so lots of good content there. You can also join our Facebook group, SA Lighthouse Adults and Seniors Programs, and you can hear some of our content at Owl Radio. Owl Radio is a group in San Antonio that reads the San Antonio newspaper on air twice a day. You can visit them at owlradio.org, and you can listen live, or you can click on the podcast page to see some of our listen to some of our recorded content.
Have a good day, everybody.
Take care. God bless.